I am Chadi Alraies. This is CVI 2019, Denver, Colorado. With me, Dr. Perwaiz. He is interventionist at Northwell, and he's the co-director of the Interventional Cardiology Fellowship and director of the New Chief Fellowship.
That's correct.
Dr. Meraj, welcome.
Thank you.
So today we're going to talk about some kind of techniques in interventional cardiology. You are giving a talk today about DK crush.
Yes.
So can you tell us a little bit about the data, why DK crush is the preferred technique at this point?
So it's very interesting. So bifurcation techniques have come a long way. And we remember the days where people were just doing simultaneous kissing stents, or they were doing provisional stents. And we've come a long way in the progression, and one of my slides will show the progression of the crush technique too. So we're very fortunate that Dr. Chen in China, put together the DK Crush 5 trial most recently, and in the trial he made it very clear that in large bifurcation vessels, especially distal left main, LAD circumflex, Medina 111 classification bifurcations, that the DK Crush was significantly better than a provisional stent strategy. And it's a very technically specific technique, and so it requires patience, which most interventionalists don't have a lot of patience, unfortunately. But it requires patience, and you have to really go through all the steps. It's a double kiss crush technique. You kiss after every stent placement, and you pretty much kiss at the end after all the stents are placed as well. And you have to rewire the jailed side branch a few times. But it's a very good technique, and if done correctly and if done accurately, it can be very good. If it's done in a rushed fashion, or if it's done incorrectly, there's a lot of imaging data that suggests that it's not as effective as it could be. But I think that is currently, in my opinion, it is the default strategy for large vessel branch bifurcations. My talk today is going to be on the con. I'm actually going to be speaking about how DK crush is not for all bifurcation lesions. So it'll be interesting to see how that's received. But I have to say, for distal left main bifurcations, it's definitely the right way to do it. For all other bifurcations, to be very honest with you, unless and until it's a very large side branch, most of the time a provisional approach or provisional with a bailout approach is probably the best strategy.
And for left main lesions, this also comes a lot of debates. When do you consider hemodynamic support versus no hemodynamic support? So
there are a multitude of factors. One, we used to just look at the ejection fraction, and unfortunately ejection fraction is not really enough to tell us what the real problem is. So we have to look at also the hemodynamics, the invasive hemodynamics. So the invasive hemodynamics really require you to swan the patient. In some cases, a left end diastolic pressure, LV end diastolic pressure, will be enough to tell you. If it's very high, you know that you probably should optimize the patient before you do anything. But you need a swan to see what the cardiac output is, cardiac index is, and what the filling pressures are. And then on top of that, you also need to understand the anatomical and procedural considerations. So if you're looking at an unprotected left main with a left dominant system, it's a very different scenario than a small circumflex with a large right dominant system, and then you have just essentially a left main going into an LAD. Totally different vessels, totally different ischemic burden during the procedure, so you have to take into account the ischemic burden of the procedure as well. And the last thing you have to look into is vessel morphology or plaque morphology. So if it's calcified and requires atherectomy, that's a very different scenario where we all know that atherectomy causes much more ischemia than non-atherectomy cases.
Prolonged procedure, atherectomy, distal embolization.
Correct, and you can have a more effect, and we know from PROTECT 2, from Bill O'Neill's data that suggests that those who had hemodynamic support, you performed more atherectomy because you felt more comfortable doing it because their hemodynamic collapse was less likely to occur.
And is it true also you feel the same as by prolonged inflations too? You have the support there, so you feel like you can go up and say for 40 seconds on the left main.
Correct, and I think that it's a people who did unprotected left mains before hemodynamic support, they mastered the art of quick up and downs, right? The quick inflation, quick deflation of stents, and they would dilute their contrast as much as possible so the stent would deflate as quickly as possible. And they had to do that because if they didn't do that, they caused prolonged ischemia. With the hemodynamic support, there's no doubt you can actually allow for better prolonged inflations. And we all know that certain scaffolds require prolonged inflations to be fully optimally deployed. So it's a better thing to do.
In your practice, what is your final result or lesion optimization? Do you do IVUS or OCT?
So we do both. For large vessels, we'll typically do IVUS. It tends to be a little bit better, a little bit easier to use, and also a reason being is because OCT requires you to have a bolus of contrast, and in a larger vessel, it's harder to completely opacify a large vessel with contrast so that there's no blood, because blood will completely dilute your image quality for OCT. OCT is by far a much more high definition image. You can see so much more. You just have to understand, I think, the most important part of imaging, which was mentioned yesterday in the complications course, is that everyone knows how to image, but not everyone knows how to read those images. And I think that's the part that we as a community interventionalists need to be better at.
Yeah, that's true. So what I understand from you is DK crush is the preferred way for bifurcation. So do you use the same technique also for the branches? Let's say a big diag from LAD or a circ-OM?
So if it's a large diagonal branch, greater than a 3 millimeter diagonal branch, yes. If it's a smaller diagonal branch, a 2.5 millimeter branch, I'll try to do my best to not put a second stent in. So provisional stenting, maybe balloons predilate the side branch, maybe use cutting balloon, an old method that would allow less plaque shifting into the side branches. So there are a multitude of methods and techniques that you use, but it's all patient and lesion specific. I don't think you can say one technique works for every patient. You have to look at the patient individually.
Last comment about the DK crush, guide size, radial or femoral?
The beauty of DK crush is that you don't need the large guide because you're never really putting two large things at the same time. So it's all sequential. So two balloons and two non-compliant balloons in today's day and age can easily fit through a 6 French guide. So you can even do 6 French for everything and easily stay radial. If you felt more comfortable doing 7 French, and if you have a large enough individual, there's no reason why you can't do 7 French radial. It's completely reasonable and completely doable.
I'm taking advantage for one more question.
Sure.
Is if somebody on AFib, he's on apixaban, and is coming for DK crush, left main, LAD, circ. And what's your regimen for triple therapy?
So typically right now, and unfortunately the data is very divergent. So the only real evidence we have for the use of triple therapy is in older studies, right? So we have the WOOS trial, which again didn't specifically look at this patient population, right? Right. We have Rocket AF, which also did not look at this particular patient population. There are a lot of these studies that didn't really look at this particular patient population that we're extrapolating the data.
And the guideline doesn't help.
And the guideline absolutely does not help. And so the truth is that even ISAR triple, which is an older study from the German group, also looked at this patient population, but looked at it in a different era, and the duration was different. So currently the guidelines pretty much say 3 to 6 months of DAP therapy alongside your anticoagulant, whether it be Coumadin or NOAC. I think we have all become much more comfortable with a minimum of a maximum of 1 month of triple therapy, and after which we keep them on usually clopidogrel and the NOAC or clopidogrel on the Coumadin. But some people are even doing 2 weeks, and some people, and the most recent data is starting to suggest that you can just do NOAC plus clopidogrel or NOAC plus Brilinta straight from the beginning at time 0. I think you have to take account the patient, the bleeding risk. If you have a 90-year-old patient that you're doing this in, it's very different than doing it in a 55-year-old person who otherwise doesn't have as many risk factors. So take into account the patient, the population that you're looking at.
But the general rules, as you said, clopidogrel is not other potent P2Y12 inhibitor, and also NOAC has also associated lower bleeding than warfarin.
Yes.
And aspirin probably dropped after 4 to 6 weeks.
Yeah, absolutely, and maybe even earlier. And I think as the data comes out, the nice thing about current modern generation drug-eluting stents is that they're pretty safe. And so you can probably get away with short-term aspirin therapy. And so we may never see a trial, but I think there'll be enough registry data to suggest that 2 weeks might be enough.
That's great. Thanks, Dr. Meraj, for your time. Always a pleasure to talk to you. Please watch this video and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Thank you.
Thank you.